I'm sure you've seen it before. Some groundbreaking new report in USA Today about some medical study that seems like it's basically a miracle drug or a wonder drug.
The conclusion from observational study as if it was the conclusion from randomized control study.
Correlation,
Right.
maybe not causation. Was that
Exactly.
it? Recommended by 9 out of 10 doctors. What should I take away from that?
50% drop
Okay, for a drop is in
of mortality in
okay.
colon cancer. However, in absolute risk, that's less than the 0.1% difference. And they were able to replicate only like 10 to 20%.
Really?
Yeah.
Wow. Thanks again for the SpeechSage AI and Healthcare podcast. I'm Noel Vandal as acting as host today. And we have Dr. Joseph Yoon, who is our interviewee. And today we're going to be talking about, I'm sure you've seen it before. Some groundbreaking new report in USA Today about some medical study that seems like, it's basically a miracle drug or a wonder drug. And then maybe a few months later, it's not redacted, but it's kind of like, there's a reason why people aren't using it or something along those lines. But when you look at the original report, they weren't lying, but maybe they were not stating the full truth, whether malicious or not. And I would just love to talk about that concept or that aspect of healthcare. What are the stats? What are they actually saying? How do you interpret this and not get caught into all this? And I'm dropping you a bomb here, but if you can take that.
Yeah, sure. So as a physician who's been trained in evidence-based medicine and how to design and conduct studies, and when I read often those lay people's publication and media, how they report findings in medical journal articles, there are a lot of misleading aspects to it because their purpose is to sell their articles for
academic journals purposes to sell.
No, the lay people.
Oh, lay people journal.
Yeah,
okay.
so like the CNN or
sure.
let's say Time magazine.
Sure.
Their purpose is to sell the publication. So I guess they have to be a little bit use varnished truth to sell their publications and becoming sensational.
Yeah, right. Well, fear sells too. That's true.
And what I see, probably the most important confusion that I see in their reports is often they confuse a conclusion from observational study as if it was the conclusion from randomized control study. So observational study is where, you look at people who drink coffee, for instance.
Sure.
And then they had, in that group, they had fewer incidents of dementia, let's say, compared to people, non-drinkers, people who have not drunk coffee. So the conclusion is the coffee drinking was associated with fewer incidents of dementia.
Correlation.
Right.
Maybe not causation. Was that it?
Exactly.
Okay.
So it's very difficult to draw a strong conclusion about causation when you are doing observational study, because in this case, coffee drinking, maybe people who are drinking coffee have other traits within them that kind of pre-selects people who are less likely to develop dementia.
Sure.
But not necessarily coffee drinking was what prevented dementia.
Right. Well, is that something then that's kind of because there is a potential for a correlation or Because you don't know of that, is it that study then kind of ineffective, or are there ways to kind of work around that?
No, I think it is a very important. It gives us a very important clues.
Okay.
But what's important is that we should take it with a grain of salt.
Mm-hmm.
It's not conclusive to be able to say that coffee drinking then can prevent dementia.
Sure.
It was just association.
Yeah, which could be valid, but
right.
it might not be.
So then usually in the medical scientific community, the next research study that is conducted is a randomized control study. Okay. So that's kind of going closer to the causation.
So what does that look like?
So you select one group of patients or subjects, and then randomize them. And very important that these two groups have a similar distribution of different qualities. Okay. So as to that the two groups are equally mixed in many different aspects, so as to assume that whatever trait and quality that could contribute to influencing the outcome is equally distributed, so we can measure the effect of the intervention correctly. So then the next study in this type would be recruit a subject, let's say 1,000 people. Yep. And randomize the 1,000 people into 500 and 500. And make sure that 500 each group have an equal distribution of many different characteristics. Okay. So that you randomize it fairly. Sure. And then, only then, you give coffee in one group and the other group none or very low level. Then follow them with this intervention. Then follow them many years and see what the effect was. Okay. So in this case,
that takes a long time.
Yeah, it takes a long time and a lot of money. Right. And that's why it's difficult to do, and we don't see this type of research in the especially nutrition field. Okay. Because it's so expensive, and it is expensive to do this. Mm-hmm. And it is also expensive to make sure that people do what we ask them to do. Oh, yeah. And we've talked about that before. Even for people that have a symptom like a disease, you can't always get them to take the medication consistently. Right. So I could imagine a randomized trial where you're healthy. Yeah. And you also may have to make sure that in the non-intervention group, that they don't drink coffee. Right, exactly. Which is more difficult to... Just do it in Utah. Right. No, just kidding. So, if they get up in the middle of the night, surreptitiously drink coffee. Yeah. Unless we are able to monitor that. Sure. Maybe like a blood caffeine monitor. Right. I don't know if that's a thing. So, it's very expensive. So, that's why it's difficult to do. But without that level of randomization and controlled study, and also in case of medication, we also want to try give them placebo to make all the conditions equal in both groups. Sure. And then also, we want to make sure that the bias of the people who are conducting studies don't go into the influence the study. Mm-hmm. So then it's blinded. Right. So the people who are conducting the study, they are not aware of whose medication is the real medication, right, and whose medication is the placebo, dummy medication. Sure. So under these circumstances, then we can remove as much bias as possible, and then we can really know what the effect of the intervention was. That makes sense. So I guess that leads me to two bigger questions. The first one being, when the FDA, what is the official medical procedure
for doing these types of trials? I know you went through like the randomized trial and the controlled trial, but is that the perfect use case for how to do that? Do you do, I guess in machine learning, we do what's called ablations. Do you like, is there a standard procedure that people use if you want to get like almost 100% certainty that this correlation is a causation?
In case of a FDA, the FDA is commissioned with keeping U.S. population safe. And so they want to make sure that the medication or medical devices are safe.
Right.
And so that's the mandate, but they also recognize the difficulty of all this, trials and the expenses and cost. So they don't demand this level of evidence for all new medication or devices that comes into the market. If, for instance, if the device is a Me Too device, so we know it exists in the market, and that this is a modification or a slight improvement from that device or medication, then they would require not the whole randomized clinical trial, but more about the safety, how sense. Safe this is.
So that's already been proven to some extent.
Right.
Yeah.
So it depends on the what the device and what the medication or therapeutics is about.
Sure. And then I guess the second question is more on the consumer side. As a consumer, I go to the grocery store and I see a bottle of Crest and it says, recommended by 9 out of 10 doctors. What should I take away from that, you know?
Well, so...
and I know that's just an example. I feel like that happens very often. So how do you, as a person, a consumer, try to filter out, okay, this is actually relevant versus not?
Yeah. Well, I think we all should take that with a grain of salt.
How big of a grain?
Well, depends.
Okay.
That's the answer. Well, because... Who are the 10 doctors?
Well, probably people paid by Crest.
Right.
Who's the one, right?
Yes.
No.
So if they were truly scientific, then they would have go through the physician list.
Yeah.
Or perhaps a list of experts, and then randomize.
I bet they don't do that.
Yeah, I bet they don't either. The random selection of those experts, so that they don't just select people who are biased or have incentive,
right,
or disincentive to say one way or another.
Sure.
Then only then that type of sampling and then the inquiry would have a scientific, reasonably scientific basis of opinion poll.
That makes sense. I saw it was like it's a joke, but it was talking about like colon cancer or something, and it was like 9 out of 10 people suffer from colon cancer, and it was a meme. It was a picture of the one guy that enjoys it, you know.
Yeah.
But,
so I think that's a lot of that's one area that many lay people, and also to a certain extent healthcare providers too, unless they had the specific training in biostatistics, more than what's required during medical school curriculum, because we only get about 2-week course of biostatistics.
In your entire medical training?
During medical school.
Yeah, during medical school. 2 weeks, wow.
Then in addition, then during residency, some people who chooses to go into research or academics, then they may get additional biostatistics.
But if they didn't do that, nothing?
Right, then their level of understanding may be, unless they continue to self-educate in this matter.
Sure.
If that's all they had and they consume medical literature, then their level of understanding is stops at that. So that's why the it is very important that the opinion leaders have this type of a training and convey the right message.
Right. I took a probability class in college in my engineering degree, but I remember. There's a quote by Richard Nixon. He basically said, "There's lies, really bad lies, and then there's statistics."
Yeah.
Or whatever he said. That's a
right.
tongue-in-cheek.
Mark Twain might have.
Maybe it was Mark Twain.
Yeah.
Yeah.
Yeah, and you know that based on different experiences with this. One good example in medical literature is the relative risk versus absolute risk.
Relative. Okay, what is that?
So let's say this medication had a 50% drop.
Okay. The drop is in
of mortality in
okay.
colon cancer.
Sure.
But so that's the relative risk, because 2 people in control group died from and then 1 person died in the intervention group,
tiny sample size
out of 1,000 people.
Yeah, so 50% better.
Yeah.
Wow.
However, in absolute risk, that's less than the 0.1% difference.
Right.
Clinically, it's almost irrelevant.
So how often do you think when people do marketing, is it that the first scenario? Do you feel, is that often?
Well, I think oftentimes, because the in medical literature itself, they claim the relative risk reduction was 50%.
Right.
Interesting. And so I think that's why perhaps and then that's a very sensational message.
Yeah, looks great.
So the medical journalist take that, and then that's what he writes.
So then what happens then if you have someone that's coming to replicate it? That's almost like a stochastic variable. It's pretty random. Almost in the realm of randomness, I feel. When these things happen, is it common then that when people try to repeat it, they're not able to?
Well, so that's the reason why often we don't take first significant medical research result at the face value.
Oh, those kind of like a little suspicion.
Yeah, it depends on the what type of things there are. If it is, let's say it's a very rare disease and it's very difficult to do research, then you may have to go by that one study that we have.
That's all you have.
Right.
Yeah.
However, if it's let's say a heart attack that happens often, one medication that works in one study, it may get approval, but then people will do another trial and another trial. So with the multiple trials, then the most physicians would, maybe not most, but some physicians may wait until the multiple study shows the consistent result.
Right.
And that's the reason why when you go to a doctor and demand you be given this medication that you saw on the advertisement on TV, your physician may not recommend that.
Right.
Because it's too early to tell.
Sure.
And the medical history is laden with many initially significant results that fail to replicate.
Lobotomies come to mind.
Yeah, so there are a lot of there is a term called replication crisis.
Yeah.
I think there was somebody who tried to replicate a number of psychology research that has been published and was accepted within the psychology community, and they found that
they couldn't.
Yeah, over half they weren't able to replicate.
Sure.
In medicine too, I think there was some pharmaceutical company tried to replicate basic science research, and they were able to replicate only like 10 to 20%.
Really?
Yeah.
Wow.
So, why is that? Maybe it's the small scale study under the lab condition may yield different results. But also at the same time, there is a humongous pressure on everyone in academia to publish.
Right.
It's you either publish or perish. And that pressure may play some role, and also publication bias too.
Right.
The famous journals are reluctant to publish negative results.
Interesting.
Yeah, so they have a definite preference for positive results over negative results. But for us to be able to judge whether this intervention works or not, the physicians, as a consumer of those research studies, we need to know how many studies failed and how many studies showed the consistent results.
Right.
Right.
Which is, to the point of the researchers, that's more time, more effort, more money, and it's not directly relevant to their particular publication. So they're not going to be incentivized to want to do that. So it makes sense. But you, as the reader, should do due diligence if you're going to interpret it correctly.
And also, ultimately, for the patient's safety.
Well,
and,
right.
We need to know the whole picture of how the research went. So that's another reason why we see this favoritism towards positive results, and
no one likes hearing bad news.
Yeah, or non-profitable.
Or non-profitable, right? Exactly.
News. So that's another reasons behind this replication crisis and sensationalism. So we should be. All of us should be mindful of all these. And so when we listen to the news about latest findings of research, we always have to be, have a mindset that with a skeptical eyes and ears, and make sure you talk to the healthcare providers who have looked into this more carefully and choose wisely, because there's so much profit motives these days. Healthcare compared to 30 years ago, I feel like I have become commercialized so much more.
Sure.
It was back then, I think I felt like it was just the drug companies who had the profit motives. But now we have everything got big, including medical groups, and they are often bought out by private equity group who has instant profit motives, and all this created the atmosphere of putting profit, perhaps not at the utmost interest, but the significant interest at the expense of patients' well-being.
Sure, that makes sense. Well, thank you for enlightening us on how to be better prepared when we read super big headlines that promise that they solved cancer or something like that. Now we can be more educated as to, okay, let's read into this a little bit more. So thank you.
Yes, thank you.